Honestly, this is a topic which is still in the gray zone. There are times when we keep on changing with definitions and all the criteria with regards to this particular. It is still something we need to explore, and we need to be vigilant enough to conclude or jump onto this particular diagnosis. The diagnosis, as we discussed, would depend on androgen excess, that might be clinical, that is like hirsutism, and acne, unresponsive to topical management. Now, this is particularly important because acne is much more common in this particular age group. And hirsutism, it is not common, but still, this particular two things need to be unresponsive with regards to topical management. Ovarian volume, again, this is particularly of importance that after menarche, at least 1 to 4 years is a zone where ovarian volume will be of maximum size. So enlargement of ovary needs not to be taken, as a literal meaning of PCOS. 1/3 of adolescent PCOS would be having metabolic syndrome, which is a sign to be worried for the patient. The uniform agreement with regards to management of adolescent PCOS is lifestyle changes being the first line management. Nothing else needs to be done, and no pharmacological therapy needs to be started. Transdermal patch is not recommended for females or girls having more than 90 kg of weight because it was not found to be effective in that overweight or obese females.
We have with us tonight Dr. Munjal Pandya, Assistant Professor at AMC MET Medical College, Ahmedabad. He is also the Honorary Secretary of Ahmedabad Obstetrics and Gynecological Society.
Thank you so much. Thank you so much, Dr. Nivedita, for the kind introduction, and Team Medflix for this opportunity of sharing my views on adolescent PCOS. Honestly, this is a topic which is still in the gray zone. There are times when we keep on changing with definitions and all the criteria with regards to this particular. It is still something we need to explore, and we need to be vigilant enough to conclude or jump onto this particular diagnosis. So, as we know, polycystic ovarian syndrome, previously it was known as polycystic ovarian disease, and now syndrome because it is, a lot of symptoms and a lot of clinical features getting into one particular zone, that is PCOS. It is the commonest endocrinopathy with regards to the females of reproductive age group. That is like 5 to 7% of females of this particular age group would suffer from PCOS. So it revolves around basically three particular zones, that is like androgen excess, that may be clinical or biochemical, then ovulatory dysfunction that might be reflected in form of menstrual irregularities, and ultrasonographic feature of polycystic ovarian morphology. With regards to adolescent PCOS, there are basic two things: androgen excess and menstrual irregularities. The zone of PCOM, that is polycystic ovarian morphology, on sonography is something which is not reliable with regards to this particular age group or adolescent people. So this particular zone of sonography would be deferred in the absence of other clinical features that cannot be used alone or even in the combination if the other two symptoms are not significant. So the diagnosis, as we discussed, would depend on androgen excess, that might be clinical, that is like hirsutism, and acne, unresponsive to topical management. Now, this is particularly important because acne is much more common in this particular age group, and hirsutism, it is not common, but still, this particular two things need to be unresponsive with regards to topical management. Biochemical androgen excess, that is like total and free testosterone levels, need to be in higher range with regards to this particular female zone. Ovulatory dysfunction, if we can see various criteria, the one which I got onto is consecutive menstrual interval more than 90 days, even in the first year of menarche. But for all practical purposes, at least we need to wait up to 2 years after menarche to conclude this particular criteria. Menstrual interval persistently less than 21 days or more than 45 days after 2 years of menarche. So spare those 2 years after menarche before jumping on to diagnosis of menstrual irregularity. And lack of menstruation by the age of 15th year or at least 2 to 3 years after thelarche, that is breast development. So if we keep on looking at it from this particular stringent criteria, these are liberal enough before initiating any unnecessary medication or treatment with regards to menstrual irregularity. To make it simple again, this is a kind of revision. If the menarche is that within 1 year of menarche, irregular menstrual cycles may be considered normal. Up to 1 to 3 years, the cycle has to be less than 21 days or more than 45 days. After 3 years, less than 21 days or more than 35 days, or less than 8 cycles per year as a whole. And more than 1 year after menarche, more than 90 days cycle for any one cycle. So basically, we need to keep in mind this particular criteria before jumping onto diagnosis or before getting worried about the patients or self. So this particular table reflects the evolution of the criteria. Starting with 1990, they said the clinical hyperandrogenism, oligomenorrhea, and polycystic morphology on sonography, all three criteria must be present to keep it, PCOS, to stamp the diagnosis to PCOS. In 2003, Rotterdam had another criteria where clinical hyperandrogenism has to be there, then oligohydramnios, and then polycystic ovarian morphology. Any two criteria out of these three will be stamped as PCOS. One more criteria released in 2009, that is AEPCOS Society, that is androgen access PCOS Society, which had hyperandrogenism as one of the most criteria, and any of the criteria from oligomenorrhea or PCOM on ultrasonography. So this would stamp it as PCOS in the most recent criteria. So basically, what we talked about physiological, menstrual irregularity, it is also known as physiologic adolescent anovulation. Now, initial cycles after puberty may be anovulatory, and that might lead to this menstrual irregularity, as well as the premenopausal zone is also having anovulatory cycles. So we need to keep those things in mind. So this is known as physiologic adolescent anovulation. We cannot directly jump onto menstrual irregularity within at least 2 years after menarche. And PCOS is basically, as said, is a diagnosis of exclusion for which referral to the specialist is to be done, and we need to rule out other conditions of hyperandrogenism like non-classic congenital adrenal hyperplasia, hyperprolactinemia, endogenous Cushing syndrome, thyroid disorders, and other virilizing ovarian or adrenal tumors. So it is a diagnosis of exclusion. Ovarian volume, again, this is a particularly of importance that after menarche, at least 1 to 4 years is a zone where ovarian volume will be of maximum size. So enlargement of ovary needs not to be taken, as a literal meaning of PCOS. When we see sonography, reports, they keep on saying that ovaries are enlarged, all multicystic, clinical correlation required. So we are the clinicians. We need to, decide upon whether it is a diagnosis of PCOS or it is a normal physiological thing, which is to be expected at least from 1 to 4 years after menarche. The follicle number and volume would be having, great overlap with regards to PCOS as well as non-PCOS patients. So we need, again, justifying the point that ultrasonographic picture of PCOS is not of that importance with regards to diagnosis. Acne is common in this particular teenage group. So again, if it is unresponsive to topical treatment, it goes in favor of clinical hyperandrogenism. Hirsutism would require a lot of years before getting executed or before appearing clinically. So that is of importance and significance. It is not physiological. Hyperandrogenemia needs to be backed up with blood levels or biochemical levels of androgen, and it is the most important and the most useful diagnostic criteria for adolescent PCOS. So this is of importance: biochemical hyperandrogenism and even presence of hirsutism. So persistent hyperandrogenism can be there in case of premature puberty. So premature puberty is something where pubic hair appears or starts appear at around 8 years, which is not normal. So we need to take history as well with regards to this particular cases of query PCOS or suspicious of having PCOS. So these are the normal changes at the time of puberty. The GnRH release would attain the pulsatile frequency. At particular frequency or the pulse frequency, GnRH release would induce or instigate pituitary to release LH and FSH. Now, this particular LH would have its effect on theca cells of ovary, which would release androstenedione in response. FSH would work on granulosa cells of ovary, which would have aromatization of androstenedione, which would convert it into estradiol. Now, this is normal physiological cycle. With regards to adrenal glands, there will be increasing androgenesis, DHEA, that is dihydroepiandrostenedione, and dihydroepiandrostenedione sulfate, which would lead to growth of pubic and axillary hair. and normally physiologically acne as well. So this is normal physiological cycle at around puberty. What happens in PCOS? So what is the inciting event? That may not be known. The exact etiology is not known, but the cycle is known now. There will be increased pulse frequency of GnRH. We know that physiologically GnRH has to be released in pulsatile manner for having its impact on pituitary. If it is not pulsatile, it will not have any impact on pituitary. This is known in physiology. Now, this frequency will be increased, leading to more of LH release. That will induce more of theca cells, would lead to more of androstenedione release. That is androgen. Lesser FSH release would lead to lesser aromatization of androstenedione. So more of androgen will be free there, and less of androgen will be converted to estradiol. And that less of estradiol would be having impaired follicular development, which will be responsible for menstrual irregularity or oligomenorrhea, as we can say. So basically, there will be more of androgen production and less of it getting converted to estradiol. Now, this particular more of androgen would interfere with the negative feedback of hypothalamic sensitivity with regards to ovarian negative feedback. So, lesser sensitivity with regards to negative feedback, again, vicious cycle of more secretion or more pulsatile frequency of GnRH, and that will keep on running and running and running, and that would lead to PCOS and its clinical implications. With regards to insulin, it is one more villain adding to this particular cycle. Insulin augments ovarian response to LH, and it increases dysregulated LH secretion from pituitary. So it is more of a villain, instigating more of vicious cycle. Now, this increased GnRH pulse frequency is resistant to suppression by progesterone. We know that for regularity of cycle, we give progesterone, and if it doesn't work, we give estrogen plus progesterone. Other way, we call it progesterone challenge stage and estrogen and progesterone challenge stage. But this particular frequency is not responding to progesterone. It is highly associated with hyperandrogenism and increased ovarian volume in response. With regards to menarche, the PCOS girls who are obese would have early menarche, and the thin girls or the lean PCOS females would be having later menarche. So this particular thing needs to be kept in mind. It is not for differentiating PCOS females. It is about expecting what is normal for PCOS in obese and non-obese or lean PCOS patients, because lean PCOS patients are always there. It is not something where we keep on saying that only obese females would be having, or obese girls would be having PCOS. There are lean PCOS cases clinically, and laboratory diagnosis was made. With regards to sonography, there are basic two terminologies we need to keep in mind. One is polycystic ovary and the other is multicystic ovary. When there is sonography report, we keep on looking at there are multiple follicles in favor of multicystic ovary, clinical correlation required. So multicystic ovaries would be having cyst size at least one or more cyst of more than 10 millimeter. With regards to polycystic, the follicle size cannot exceed more than 10 mm. That is one basic difference. The other one is, with regards to polycystic, the stromal content is more in those ovaries. While in multicystic, the stromal content is normal. Stroma is not increased. So these are two basic differences. The third one, as they say, the polycystic one would be having its arrangement in necklace pattern or more of periphery or the cortex of the ovary. Multicystic would be more of medullary arrangement. But again, that is not much specific. We need to keep in mind the size and the stromal content in mind before jumping on to converting that multicystic into polycystic and starting with the management. No, that needs not to be done. The metabolic risk involved with this particular PCOS would be acanthosis nigricans and truncal obesity are suggestive or reflective of insulin resistance. 1/3 of adolescent PCOS would be having metabolic syndrome. Metabolic syndrome, we know that 2 or more of 4 criteria like obesity, hypertension, dyslipidemia, and hyperglycemia. So this is metabolic syndrome, and 1/3 of adolescent PCOS would be having metabolic syndrome, which is a sign to be worried for the patient. Abdominal obesity, there are chances of greater metabolic syndrome when there is abdominal obesity, and that is why the screening of metabolic syndrome needs to be done at regular interval so that we can timely manage that particular syndrome. This particular table suggests the criteria for metabolic syndrome in adolescents. Any 3 of the 5 criteria out of would be present would lead to diagnosis of metabolic syndrome in adolescents. Blood glucose level more than 100 milligram per deciliter, that is random blood glucose level. HDL cholesterol less than 40 milligram per deciliter, triglycerides more than 110 milligram per deciliter, and waist circumference and blood pressure more than or equal to 90th percentile for that particular age and sex. This five criteria are there. Any 3 out of 5 would lead to diagnosis of metabolic syndrome in adolescents. This is a vicious cycle of metabolic syndrome. Hyperandrogenemia is the core problem here. It leads to various effects on ovary and other tissues, and that particular cycle would lead to, as discussed, obesity, hypertension, more of insulin resistance, and dyslipidemia. So we need to keep in mind this particular cycle, and we need to break this particular cycle for having optimal health outcome with regards to patient. Now, what if the patients are presenting with PCOS like symptoms? We need to rule out other problems. So to complete the list of laboratory investigations, we need to have TSH to rule out thyroid, prolactin. Now we need to know that there are 2 or 3 readings of prolactin that our laboratory needs to take before jumping on to diagnosis of hyperprolactinemia, because it is a kind of hormone which would reflect the stress, just like TSH. And previously it was thought that TSH needs to be done in a fasting state. No, now it can be done at normal non-fasting state as well. DHEAS and total and free testosterone level to diagnose the biochemical hyperandrogenism or anything other than PCOS leading to hyperandrogenism. 17-hydroxyprogesterone for CAH, congenital hyperplasia of adrenal tissue. Ultrasound of ovaries. Then FSH, LH, and estradiol. Once PCOS has been confirmed, the fasting and 2-hour OGTT for ruling out development of type 2 diabetes mellitus, lipid panel, and fasting insulin needs to be done for diagnosing or for concluding or evaluating the hyperinsulinemia or insulin resistance. So how would a girl of adolescent age group would present? She would present mainly with the concerns having menstrual irregularity and physical findings of acne or hirsutism. Hirsutism, definitely an abnormal finding that needs to be worked up properly, but acne may be common. But acne associated with menstrual irregularity needs to be taken seriously with regards to hyperandrogenism. And electronic medical record documentation. Now, every consultation would be having laptop or PC. So we can take photographs of those patients at initial visit and regular interval with regards to evaluation of the management that we are doing with regards to this particular case. So we need to have images at the baseline and during follow-up visits after informing the patient. So this is good and particular medico-legally safe as well as satisfying on the side of patient for us to explain. This is modified Feynman-Galloway score. More than 8 would be having hyperandrogenism or clinical hyperandrogenism. Various sites like upper lip, chin, neck, upper chest, lower chest, upper arm, lower arm, back, and pubic region needs to be evaluated, and the scoring can be charted accordingly, and the total score needs to be done. So this is particularly of importance with regards to hirsutism. We know, I think many of us would know this particular lady. Her name is Harnam Kaur. She lives in UK, and around in 2014, at the age of 24, she came out publicly with regards to this hirsutism. She was tired of removing those hairs, and in 2016, she was awarded Guinness Book of World Record with regards to a female having the highest length of beard. But this is of significance. I put this particular slide because even if diagnosed with PCOS, we need to have courage for getting ourselves treated, for getting patients treated properly, but at the same time not having lowered self-esteem or not getting into depression, because it is nowadays epidemic of depression. We keep on talking about depression because some XYZ actress talked about it. It is not a style. It is something where everybody goes through it, but we need to deal it courageously. That can be done easily, So we can get inspired out of those cases. So these are laboratory investigations we talked about, because we need to step diagnosis of PCOS and we need to rule out other conditions. So free and total testosterone and DHEAS would rule out ovarian and adrenal androgenic tumors. Morning 17-hydroxyprogesterone for congenital adrenal hyperplasia, and LH-FSH ratio. Now this is amazingly important, because we keep on writing or prescribing LH and FSH on third day of menses after withdrawal in these cases. If it is more than 2:1, we constantly jump onto PCOS. But no, various studies have shown that it may indicate it. It is not conclusive of PCOS, and even in its absence, there might be possibility of PCOS. So it is not confirmative. It may help us to jump onto that particular diagnosis. So the management is required basically for patient education. We need to educate the patient. We need to tell her that what is going wrong and what is not actually going wrong. We need to have a healthy lifestyle. Healthy lifestyle, we all are aware. We call it in Hindi, Sampurna Ahar. We need to avoid fast food. We need to have exercise. Just because XYZ person is doing exercise and that is why we start doing it, it is wrong notion. We need to do it for our body and for ourselves. So a healthy lifestyle needs to be followed, and emotional well-being. We need to have a circle. When we were kids and in school, we had better friends than we made friends in college and even in practice. So those school friends were, having no motive of friendship. They were actually pure friends. We need to have such friends. And if we do not have it, we have parents. Even though we have studied, a lot of books, we are studying a lot of books and medical sciences that our parents might not have gone through. Still, they are better cushion, as compared to any other cushion in the society. So just keep your mind open, just keep your eyes and ears open, and just keep yourself open towards whom, who are trustworthy. Not towards who can actually misuse your details, but that shouldn't make you doubtful with regards to this particular sharing zone. But yeah, keep yourself open to your close ones, and then a lot of things would make sense, and a lot of support will come on its own. So do not feel good, do not feel superior when you are being that particular support. But yeah, start expecting support from your trustworthy people, and do not miss an opportunity of being a support for somebody else. So the goals of managing this particular cases would be management of menstrual irregularity, which is bothersome as well, reducing the hirsutism and acne, reducing type 2 diabetes mellitus, and it's preventing the development of it, reducing cardiovascular risk in case the longer zone of PCOS would lead to more risk of cardiovascular zone, reducing endocrinal, it's a mistake, reducing endometrial carcinoma risk, and improving quality of life, and improving or preserving the fertility. So the uniform agreement with regards to management of adolescent PCOS is lifestyle changes being the first line management. Nothing else needs to be done. First, lifestyle management. Nothing else needs to be started. No pharmacological, therapy needs to be started. So what are lifestyle changes? These are like diet, exercise, and weight loss. These three are particularly of importance and suggested and backed up by all the global societies. Weight loss would actually be the single maneuver, decreasing the androgen production, improving insulin sensitivity, and reducing cardiovascular risk. So weight loss is something which would start the zone, and exercise would maintain that particular healthy zone. So exercise does improve hyperlipidemia, beneficial effect on metabolic and anthropometric and cardiorespiratory fitness. So weight loss, exercise, and proper dietary control or regulatory control would help in managing most of the adolescent PCOS cases. We need not to jump onto pharmacotherapy with regards to improvement in this particular zone. So dairy products, what would be your ideal weight, and we can evaluate ourselves. We can guide our patients with regards to dietary regulations, like the portions would be covering the fruits and grains and vegetables and proteins. No, not more of fat, not more of carbohydrates. And sports person would be having different proportions of carbohydrate as well. So recently we had concept of zero carbohydrate diet and more of keto diet and everything. But anybody could choose what works for the self or the person. So with regards to pharmacotherapy, the OC pills and metformin are most commonly used drugs, and they do respond well with regards to hirsutism and acne as well. Anti-androgens, orlistat, that is like anti-hunger drug, popularly known as vitamins and supplements, and for acne, additional topical and oral medications can be started. So OC pills, it is first-line pharmacotherapy where estrogen content, ethinyl estradiol, can be around 20 to 30 microgram or even 15 microgram would work. That is lower dose oral contraceptive pills. OC pills works best for hirsutism and acne. Nothing else needs to be started in most of the cases. Basically, it interferes with the hypothalamic pituitary ovarian axis. It increases sex hormone binding globulin, and that is why the free androgen level drops. And that is how it works. It leads to improvement in unwanted hair growth in at least 50 to 70% of hirsute females. It is the most effective therapy for hirsutism. Transdermal patch is not recommended for females or girls having more than 90 kg of weight because it was not found to be effective in that overweight or obese females. Insulin sensitivity does not get improved in this particular ossiples, and estrogen has its own impact on VTE, as it is said that ossiples and obesity would have 10 times more risk of development of venous thromboembolism. So this particular thing needs to be kept in mind, and we need to keep in mind the common contraindication and side effects with regards to ossiples. And 14 years, I have written this particular thing because there are times when adolescent PCOS females go to some other doctors, non-gynec or even some doctors, they start the ossiples directly. Now this is not recommended. At least up to 14 to 16 weeks, you should not start ossiples because there will be earlier epiphyseal fusion and stunting of growth will be there. So we do not want it. So ossiples must not be started at least before 14 to 16 weeks, 16 years of age. So 16 years, before 16 years, just let the lifestyle changes float. After 16, if at all needed, then only you can start the oral contraceptive pills. Anti-androgens need to be started if the oral contraceptive pills for 6 months have not delivered results, or else they work well. There is no need of anti-androgens, even if there is hirsutism. And if there is alopecia. So alopecia and non-responsiveness after 6 months of ossiples therapy would lead to addition of anti-androgen. Nowadays, there are oral contraceptive pills with anti-androgen component. So we can use them. And we need to keep in mind cultural and social factors. So it is not the perception from our side, it is actually patient's perception of severity, which needs to be taken into consideration before starting this particular therapy. So one of them would be spironolactone. It is basically competitive androgen receptor antagonist with diuretic action, that is potassium sparing, typically used along with ossiples. Not commonly used because it has its own side effect in form of menstrual irregularity, and it is teratogenic. So patient must not get conceived if or when on spironolactone. Potential side effect would be electrolyte disturbance and hyperkalemia. The dose is 50 to 200 milligram per day in divided doses, and other options like sapropterin acetate, flutamide, and finasteride. But again, long-term treatment would lead to hepatotoxicity in this particular cases. So we need to have LFT or liver function test checked. Metformin, insulin sensitizer, very famous in addition to ossiples. It decreases hepatic glucose production and increases peripheral insulin sensitivity. It has potential to prevent development of type 2 diabetes mellitus along with dyslipidemia, and which actually stems from insulin resistance. Now, there is one more molecule, that is N-acetylcysteine, which was found to be superior to metformin in effect as well as side effect profile in one of the recent studies published in 2019. So right now metformin is being used properly practically, but it may be replaced by an acetylcysteine. Systemic therapy can be, the therapy which we give can be augmented by topical or mechanical treatments for hirsutism, like electrolysis, laser therapy, plucking, waxing, epilation, depilation, they call it in cosmetology language, and topical therapy for acne. And for acne, topical retinoic acid and antibiotics can be helpful in addition to oral ones and other hormonal therapy. Mood disturbances, we cannot ignore the problems they are facing from inside. So poor self-esteem and depression needs to be treated before, along with, this particular pharmacotherapy and lifestyle changes. Metformin therapy for 90 days was shown to be effective in reducing anxiety and depression in this particular cases. And counseling is of utmost importance. There are particular zones in our country where counseling is now a trend. You feel low, you just talk with people. But it has to be utilized medically. It has to be utilized optimally in each and every zone of the country. Why it has been neglected? Talking it about is not, a taboo. But again, opening up like just for style and showing off is not something recommended as well. We need to find the balance, and we need to be a good counselor along with being good clinician. Vitamins and supplements, vitamin D and probiotic were experimented for these patients, and they found to be having improved general health and improvement in scores of depression, anxiety, and stress. So this is of great importance. It is not having problem or complications or side effects, but it is having it is working as a boon without having much of hormonal changes. Significant reduction with total testosterone, hirsutism, and C-reactive protein was noted, and increase in antioxidant capacity. That is like antioxidants, removal of free radicals. Vitamin D was beneficial for follicular development of ovary and menstrual regulation, and omega-3 fatty acids were found to have short-term beneficial effects for mental health and other inflammatory markers. Orlistat, famously known as anti-hunger medication, reduced weight, and it might lead to decreased cardiovascular risk and improvement in lipid and glucose profile. It was found to be more effective, having lesser side effect than metformin. But again, practically metformin has been in continuation for all practical purposes. But these molecules are new on horizon, which are long-term considerations. The contraception, adolescent females who are not married may not be jumping on it, but yeah, now they have a choice, so they can use the contraception of their choice before getting conceived with PCOS. Daughters of females who had PCOS were found to have highest AMH and lowest FSH, having more of follicular numbers and more of ovarian volume as compared to the daughters who of the females who did not have PCOS. This was particular study because from the initiation or the prepubertal phase, these ovaries are large enough. So this daughters need to be monitored or vigilantly monitored for development of PCOS in their own life. There was increased glucose stimulated insulin, and a consistent phenotype of this particular daughters had PCOS like picture, but that again would not help in being confirmative of having PCOS in those females. So increased PCOS, increased AMH level, that is anti-Mullerian hormone level, was associated with increased leptin and other inflammatory markers, and increased insulin with regards to in response to glucose prepubertally. And it appears that girls at risk of PCOS based on hereditary have evidence of an increased follicle complement and mild metabolic abnormalities compared to controls. So they need to be monitored properly. With regards to long-term implications, infertility is one of them. So again, in our country nowadays, career development has been given priority, which is not wrong. But yeah, at the same time, the definition of infertility has changed a lot. By definition, it is like 12 months of unprotected intercourse, not leading to result. But nowadays, people are getting married late, and then they are apprehensive suddenly out of nowhere because of societal pressure, because of personal pressures of not getting conceived, and they suddenly consult the fertility experts. So you need to actually fulfill the criteria of being infertile before jumping onto this infertility zone. But yeah, there might be fertility issue majorly with regards to PCOS and obesity, and that can be tackled easily by again those previous modalities, and if not, then they need to be monitored in form of ovulation study, and then only you can jump on to starting with ovulation induction medications. The other one is endometrial carcinoma. Now again, we can prevent this particular risk by being vigilant and being monitoring them properly before getting onto that earlier or later stage of carcinoma zone. Diabetes, type 2 diabetes mellitus is pretty much common to develop in this particular females having PCOS for longer duration. So again, monitoring would be required, and thyroid and other metabolic syndrome need to be taken care of. So take-home messages would be pelvic sonography is not must. It is not one of the criteria for adolescent PCOS, at least after up till 8 hours from the menarche. One. Anti-Mullerian hormone. It actually came up with a lot of hope that AMH would reflect the capacity of fertility. But nowadays, people are, there are many more research papers which would indicate AMH may indicate. It is not something which would conclude the fertility capacity of the ovaries. And this particular case, adolescent PCOS, AMH is not recommended for diagnosis of PCOS. Exclusion of other disorders would be there before jumping on to diagnosis of PCOS. Screening for anxiety and depression and necessary counseling needs to be done, and multidisciplinary approach. I'm telling you this because we had a lot of discussion with regards to cosmetologists, endocrinologists, and gynecologists. Now, these three people need to come under one roof for managing one particular case. Cosmetologists cannot keep on having laser removal of hair in the absence of actually finding out the root cause. Endocrinologists cannot, keep on writing anti-androgenic, medications without explaining the risk of spironolactone and teratogenicity. And gynecologists cannot keep up, on his or her own, keep on treating it with ossicles, alone. So all the three disciplinary team needs to come under one roof for managing one particular case of adolescent PCOS, and we need to have a faith in self, in treating physician, and the Almighty. So just remove that particular taboo or eclipse we have with regards to adolescent PCOS, and just start having open mind with regards to the possibilities, with regards to the confirmation, and then the proper management of adolescent PCOS. Thank you. Thank you so much.
Thank you so much, sir, for that amazing session. So, how long after initiating lifestyle modifications should we consider OCPS?
Yeah. So basically, what is the presenting symptom that matters the most in this particular case? Whenever we are advising lifestyle modification, that means we are not dealing with actual hirsutism, the apparent hirsutism. So lifestyle modification is something where we can, continue till the person or the patient feels that nothing is bothersome, no symptom that is bothersome has developed till yet. So it is the best part for life as a whole. If she's gradually developing hirsutism or any bothersome symptom, then we can start OCPs. Till then, there is no need of starting any kind of pharmacotherapy. If she is comfortable with weight loss, dietary control, and exercise, she needs to continue it for future benefits as well, not only for PCOS. So there is no limit to it.
Thank you so much, sir. I hope that answers your question. So we have Dr. Fatima who asked, what is the right time to go with test for ultrasound?
Basically, as last slide mentioned, that up to 8 years post-menarche, ultrasound is good, fine, but then again, it is not conclusive. You cannot stamp on the basis of ultrasound that this particular patient is having polycystic ovaries. So ultrasound is not a feature to stamp adolescent PCOS, but yeah, afterwards, if you are dealing with some fertility issues or later on some other issues, not responding to medications, then it is off road, and then we can decide upon. Honestly speaking, there is no need of starting any kind of medication before 18-19 years, because you cannot allow the patient to keep on continuing this particular medication for regularization of cycle and other features lifelong. We are actually putting handcuffs on them in form of pharmacotherapy. And again, there are many cases where pharmacotherapy was started, and after 2 years or 1.5 years, some particular thing led to starting of edema, and then you need to prescribe additional diuretic, and then there would be a vicious cycle. The person would be tired of it, and don't do that. And anyway, it is not recommended. You do not want that particular body to get accustomed on the pharmacotherapy. Just lifestyle modification if she is not dealing with fertility issues and she is not married even. So I don't think anything would require ultrasound is not of any help other than radiologist confusing the gynecologist.
Thank you. We have Dr. Seema who is asking, what will be the minimum age to diagnose for PCOS?
As discussed in various criteria, I think up to 2 years after menarche, we should not be diagnosing anything because they are annual cycles we are dealing with. After 2 years of menarche, as discussed, like less than 21 days of cycle, consecutive cycles, or more than 45 days of cycles, from 1 to 3 years post menarche, or she has not developed menses till the age of 15 year, that would be the diagnosis where we can make. And hyperandrogenism, particularly the biochemical one, the laboratory hyperandrogenism, is the one which has to be there before diagnosis of adolescent PCOS.
Thank you. So we have quite a few people asking if you can reiterate the difference between PCOS and multicystic ovaries on ultrasound.
I talked about 3 points majorly. One is the polycystic ovaries not having any follicles more than 10 mm diameter. The multicystic one would be having one or more follicles more than 10 mm diameter. One. The other one is stromal growth will be much more in polycystic ones, while multicystic ones would not be having stromal growth. That is normal stroma content. And third one majorly is polycystic ones would be having necklace arrangement. That is like they are arranged in the periphery of the ovary, while multicystic will be having cysts in the middle of the ovary or medulla. But again, that third criteria is not significant. But yeah, the size of follicle, the stromal content are much more important before differentiating or jumping onto PCOS.
So there's a request for etiology for CA endometrium in PCOS. If you could explain the etiology.
So, yeah, basically, when we discuss about cervix, it is more of children giving birth to more of children, one of the criteria like HPV infection and everything. With regards to endometrium, it is this hormones, continuous presence of estrogen that would lead to more chances of endometrial hyperplasia. Now, with regards to hyperplasia, the patient would be having menstrual problems. Then we would have the biopsy if the hyperplasia is having atypia, simple or complex one, and then accordingly we can judge upon the diagnosis of or the risk for developing endometrial carcinoma. So it is a late stage we are talking about, but yeah, before that she will be developing abnormal uterine bleeding, AUB, which would be having proper biopsy before removing uterus as it is for endometrial or hysterectomy, and that is why there is significance or diagnostic significance of dilatation in curettage or endometrial biopsy before doing any kind of hysterectomy. So AUB needs to be having proper biopsy workup, which can have atypia or absence of atypia would rule out any possibility of carcinoma, but presence of atypia would have the risk of developing endometrial carcinoma. So yeah, continuous exposure of PCOS and this particular metabolic syndrome would add up to the risk of developing endometrial carcinoma.
So we have another question. Since ultrasound is not conclusive of PCOS, what is the ultimate diagnostic criteria that the patient needs to fulfill? And so then we can start treatment for PCOS.
So my second slide actually had those two important points. One is hyperandrogenism, which may be clinical and biochemical. Clinical is hirsutism technique, not responding to topical therapy, and biochemical, that is like increased free and or total testosterone. So that is one criteria. The other one is ovulatory dysfunction, which we discussed in detail, that menstrual irregularity. So these two are the criteria on which actually we need to rely on the diagnosis of adolescent PCOS.
Okay. I think so. That's it. Most of the questions you've already gone over, and so I think we can conclude the Q&A. One second. I think Dr. Ankita has put up a question again. So yes, a 17-year-old going on with PCOS workup, having anemia, is suggested to rule out celiac disease by her gynac. So is there any correlation?
I think I haven't read anywhere the association of celiac disease with PCOS. No. So I don't think it is anyway interrelated. But yeah, I will check it out, and I will try to get back if at all I find any correlation. But no, till date I haven't.
Okay, thank you so much, sir, and thank you so much, sir, for coming up on this platform with a very nice topic, which was very relevant to today's day and age, with so much of lifestyle modification happening and diet and everything. So I think the number of cases of PCOS have really gone up. So this was a really informative talk for all the residents out there. So thank you so much, and we hope to have you back on our platform soon.
Sure. Thank you so much, Dr. Nivedita and Dr. Rucha and whole Medflix team. Actually, I find it amazing to have this particular platform where you are trying to get to the roots who are actually dealing with the bulk of the patients. So thank you so much. Thank you so much for thinking out of the box